My name's Amir. Kaki, I'm an interventional cardiologist. I direct the high-risk PCI program and the ECMO program at St. John Hospital in Detroit. Do a lot of procedures that require large bore arterial access, including but not limited to Impella, ECMO, transcatheter aortic valve replacements. And we wanted to evaluate this technology to see if it could possibly help us not only with bleeding mitigation strategies, but also with the flow of our patients post-procedure. Historically, our institution, a lot of our TAVR patients, our high-risk PCI patients, obviously our shock patients, would end up in ICU. And given the fact that there was very few ICU beds and they were at a premium, this is one technology that we leveraged so that we could safely put our patients in a non-ICU environment, which allowed us to continue to do high-risk PCI elective cases, which allowed us to do TAVR patients, and gave us a layer of protection that historically we would depend on the ICU environment, but now these patients could go to non-ICU floors, telemetry and such, and really helped us with that strategy. So it was very useful. For example, in the high-risk PCI, I'm a big believer that any mechanical circulatory support case should be done with the guidance of a right heart cath, whether it's an elective patient or a shock patient. And so the early bird is a sheath, which we were going to use anyway for our right heart cath. And we put that sheath in and we do our right heart cath through the sheath. We would activate the bird after the procedure. And so once we had hemostasis that we would achieve in the cath lab, we would leave the early bird in for 4 hours, and it would be activated immediately after hemostasis was achieved. And if the early bird did not detect any bleeding after 4 hours in the post-op holding, it would be removed and the patient would be sent to a telemetry floor as opposed to an ICU floor. It's patients who have a high risk of vascular access related bleeding in the setting of large bore procedures, be it mechanical circulatory support, TAVR patients, Impella patients, ECMO patients, and the like. I think the biggest advantage of having the early bird in our early experience of using it is our ability to safely, discharge patients to units that are non-intensive care. So that's really has been the biggest impact on the practice. We've done almost between 2 and 3 dozen of these cases so far. We're going to be participating actually in a clinical trial looking at the utility of the early bird to try to see where best this technology could help us. We're early adopters of innovative technology, and so we're excited to try these technologies to see if they have a place in helping our patients. And as such, our hospital has really welcomed it. Our staff has. It's a very easy technology to deploy. It's a sheath really, so we use it routinely for our right heart caths. But as far as the nursing and the post-care, it's self-explanatory. Within 10 to 15 minutes, everyone could be in service on the technology. So it's been easy. It's been really adopted very nicely by our staff, our fellows, our cath lab staff, and our faculties.